Hi, today we're going to talk about Wellbutrin withdrawal. My name is Lyle Murphy, the founder of the Alternative to Med Center. First question I'd like to address is, what is Wellbutrin used for? Well, Wellbutrin is really in the realm of a stimulant. There's a difference between antidepressants. There are antidepressants that up your serotonin so that you have a level of impulse control. Raising your serotonin is not typically associated with what you would think of an antidepressant or elevation of your mood. Serotonin actually gives you the restraint necessary when suicidal ideation and things like that come up. But Wellbutrin is not that kind of drug. Wellbutrin is not a serotonin type drug. It's more of a stimulant. It helps keep dopamine and norepinephrine around longer in your nervous system. Dopamine is the neurochemical equivalent of reward, and norepinephrine is the neurochemical equivalent of attention. Now, if you have too much dopamine, it results in mania. If you have too much norepinephrine, it results in anxiety. So some people that take Wellbutrin can be prone to tipping over on those two out-of-range things. Also, they use Wellbutrin to stop smoking. Generally, people don't come here to get off of what's called Zyban for their stopping smoking. I'm not a big fan of using Zyban. In fact, I don't want to be oppositional to what people use to quit smoking, because obviously quitting smoking or smoking itself will take about 10 years off your life. So, using Zyban or Wellbutrin to get off of smoking, well, yeah, of course you want to stop smoking. It wouldn't be something I would think would be long-term, though. If someone can not get stuck there too, that would be great. Question number 2, why did my Wellbutrin stop working? Well, honestly, it's kind of like the same reason why a person would say, why did my cocaine stop working? Or why did my coffee stop working? There's a limitation to a substance that is not manufacturing the neurochemical that it's actually spending. So, like with caffeine, like with cocaine, you're spending dopamine. You're not making it, and that's sort of the same way with this drug. You're blocking the way that dopamine is metabolized by forcing it. You're basically blocking the dopamine transport molecules from picking the dopamine back up and holding it back in the originating vesicle of a synapse so that it can get used again. So it kind of stays out there, but by staying out there, it actually will degrade into its metabolites. It's not recycling it. And when it degrades down into its metabolites, there's not a whole lot of dopamine left to express. So it sort of has Wellbutrin typically has a nice front end effect, but the long-term use of it is sort of mixed. Some people do okay with it long-term. Most people have to keep upping and upping and upping the dose, and then they find out it's not working, and their nervous system is now bankrupt of dopamine. So the thing that they were suffering from originally now becomes hyper-magnified. It's literally a huge neurochemical problem. Even in people that may not have had a dopamine deficit in the first place. Maybe they had a thyroid that was hypofunctioning, or other reasons, vitamin D deficiency. All of the different reasons why somebody could be like lethargic. Even food allergies can do that sort of stuff, right? But now the drug itself could create the dopamine deficiency that it was meant to fix. And so that's why most drugs are truly like that. They're not sustainable in most people. And if they are, you're certainly the lucky ones. We don't hear so much from the lucky ones over here. We hear from the ones that are the most unlucky of all, really. The people that have the most absurd reactions to these type of medications. So hopefully there's a greater number of people out there having success with Wellbutrin than I would be aware of because of my particular bias. Question number 3, what does Wellbutrin withdrawal look like? Well, it looks a lot like for those of you who have any expertise in recreational drugs, it looks like coming off of a stimulant. I mean, it looks like you're in Wellbutrin is usually easier to get off of than the SSRIs or even the SNRIs because it truly is a plunge on the dopamine pathway. So it looks like a person just doesn't have reward, doesn't have motivation, doesn't have focus, has brain fog, feels fuzzy, literally might feel like they're moving through water, like their head is sort of swimming around, all sorts of things like that. And it can happen kind of quick with Wellbutrin. It can happen in the first couple of days where, you have that tank out. As with any drug, you generally want to taper it. Wellbutrin, it may be that you can taper it a bit quicker. Maybe a 25% entry cut is the right thing for you. Maybe it's not. You should definitely be having a holistic-minded prescriber, somebody who can actually prescribe this medication, but also has a mind for, hey, let's get you off of that and get you onto something that is the vitamin D or addressing your thyroid or other things. To do that, that's what we do here. We're tuning up people's metabolism using NAD therapy, working with thyroid issues. I mean, all of the things, there's a lot of reasons why a person can physiologically feel depressed. There's a lot of reasons why a person's car can be sluggish and not drive real well. All of those reasons can be worked with without having to set the car or the person on fire to do it. And that's what these medications tend to do. So the withdrawal from it, unsupported, is going to look like probably a crash into passionless, depressive purgatory hell. And there's ways that we can avoid those type of more severe reactions. And so if you're struggling, I encourage you to give us a call and we can probably help guide you through some of that. Question number 4, how can my Wellbutrin tapering be supported? Well, again, it's figuring out the metabolic reasons why the person might have been physiologically depressed in the first place. What was not functioning for them to feel like they needed some sort of mood elevation boost? People live off of sugar. That's not sustainable either. It works for a minute. People live off of caffeine. If you're using caffeine every day, especially if you're not eating, your blood sugar and everything else is going wackadoodle all over the place. That is literally going to take out your adrenals. I mean, it's those sort of mechanisms you want to look at. But specifically for helping with this withdrawal, anytime you take a stimulant, you're going to be burning out the other side of the mechanism. So your body is naturally going to want to achieve some sort of mechanism of homeostasis. So if you're revved way up, your body's going to be trying to, wait, don't be so revved up, and is going to use up all of your serotonin. So even though this is not a serotonin type drug, it can exhaust your serotonin just because it's a stimulant. Any stimulant can do that. So the use of tryptophan combined with magnesium and niacin can kind of boost you towards getting some serotonin buildup. I would preload with that for a few weeks. It's not going to necessarily interfere with the Wellbutrin. Tryptophan can interfere with other antidepressants, but not so much Wellbutrin. Then when you're coming off of the Wellbutrin, then maybe use some sort of things like tyrosine, like DLPA. Those are the sort of things we would investigate here. We have a huge panoply, almost like an encyclopedia of holistic things that we use that would be a little bit out of range for me to talk about. But here a person's well supported, specifically on the neurochemical pathways that are being aberrated and going into a certain plunge when a person's coming off the Wellbutrin. Number 5, what types of people might not tolerate Wellbutrin well? Well, this question is great. I take calls. I've taken calls for 15 years now. And even though I don't even take that many calls anymore, there's a registration staff that does that at least twice a week. Sometimes almost every day, I hear from somebody who has been prescribed a stimulant and a sedative in the same protocol. This type of medication, I personally feel from a philosophical and a pharmacokinetic perspective, should never be prescribed with an antipsychotic. An antipsychotic is restricting dopamine, and Wellbutrin is trying to force more dopamine. And I see this a lot. a person on Wellbutrin and Zyprexa, on Wellbutrin and on risperidone, on Wellbutrin and on Abilify. That is retarded. That's like trying to park your car in the garage and you're slamming on the accelerator and the brake at the same time, trying to somehow use that to get the car parked in the garage. It's like you either use the accelerator and ease it in there, or you use the brake and slow it down from going through the whatever. These two drugs do not belong together in the same protocol. I'm not telling you to change your medications, mind you. That's something for you and your prescriber to figure out. But just, think about that. Think about, why would you want to increase your dopamine when you have another drug that's decreasing your dopamine? Yeah, it is truly silly. And it amazes me that I keep seeing this over and over again. And that is why people can go psychotic. I mean, people can go psychotic just on adding Wellbutrin, especially if they're taking the Wellbutrin and forgot to take their antipsychotic, or didn't like the effect of their antipsychotic, but they really like the effect of the Wellbutrin. So they stopped taking the antipsychotic. Those are the folks that really might want to consider asking their prescriber to look at their, what sort of profile of prescriptions they're on, or maybe find a new prescriber, because a good prescriber probably wouldn't have done that in the first place. Side effects of Wellbutrin. Well, there's the side effects of taking any stimulant. Thoughts racing, dry mouth, agitation, mania, which can crescendo into long-term fatigue. It can actually exhaust the person's adrenals and stuff. So, but the main side effect of Wellbutrin is when you put it into somebody that has had, and I don't like using diagnostic terms, but I'll use them for the convenience of the conversation, that has had any sort of manic or bipolar type things. I mean, Wellbutrin's probably not the right drug for those people. And I would question your prescriber if they're considering that. You may want to get a second opinion. I can't give you any medical opinion, obviously, because I'm not treating you or your loved one. But these are the type of things that I'm bringing up that you want to bring up with your prescriber, or find a new prescriber. Because honestly, anything you hear on TV should probably not be taken as medical advice. Even in COVID, which is where we're at right now in history, there's nothing that really can take the place of an inpatient relationship with the doctor, or to have a residential facility like ours, which encompasses all of the variables, that can really strengthen and give a person a new lease on life. So if you're really struggling, I encourage you to give us a call. But at a minimum, if you've listened to this entire video, I'm hoping you hit a like, subscribe to our channel, because we're going to be going over more things that could potentially help you or your loved ones avoid being medicated as a lifestyle. All right. Thank you, and good day or good night.